Are there other vending machines around?
That's the only one.
Just in Blanchard?
No, it's not a vending machine in Blanchard. It's a vending machine in Coeur d'Alene.
Oh.
All right.
Do we have any in the building? I have some in my car. Do we have any in the building?
Bonner County does not have it. I have it, but that's the thing is it's how do we get it more visible? So it is 9 o'clock and we're here for our update with Panhandle Health. And with that, we'll turn it over to the director.
Thank you, Commissioners, for meeting with Christine and I. We're here to present our FY26 budget to you. We have had this reviewed by the Board of Health, and they've approved us moving forward to taking this to the Commissioners for final review. The budget hearing is going to be on May 15th, where the chair of each of the commissions, the 5 commissions, will meet at 1 o'clock, and will ultimately vote on approving this budget. Probably don't need to mention, but Bonner County is where we do a significant amount of the work, second only to Kootenai County. Frankly, a lot of the land development work that we do is Bonner County in recent years has exceeded Kootenai County as far as land development and septic systems and so forth. But we do provide nutritional services, WIC services, clinical services, senior programs, and so forth. I did want to share, this has been a challenging budget to build this year, in part as we monitor what's happening or what happened at the state level. There's some shifting as far as funding and what's going on. Health and welfare in the last year has undergone a significant reorganization. We're also keeping a very close eye on federal funding because there's already a few notifications where funding is no longer available or is potentially shifting. So we continue to monitor that very, very closely. We did build the budget based on the best information that we had available. But what I've told each of the commissions is that this is going to be a transitional year. There's no doubt in my mind that once the federal government finishes building their budget, we're going to have a better idea of what funding is available. And there is going to need to be a very serious conversation with the county commissioners on the best role of the health district and the funding that's provided. So we're here presenting the budget because this is budget season when we build it, but in coming months, I will be back in front of you and we will be having that conversation.
Which county is the chair for the meeting?
Benoit.
Okay,
So
I thought it was Shoshone for some reason.
Yeah, so it'll be Commissioner Lampert that will be chairing. And I guess while we're on that topic, Commissioner Williams, will you be
Yes.
attending? Okay,
Yep.
excellent. Because if there was going to be a proxy, then there's a bit of ask we have on that. So a few guiding principles that we had when we were building this budget is, as I stated, we're expecting change over the next year. We are not asking for an increase in the overall ask of the counties, so we're keeping that the same as last year. For your information, the ask from the counties has changed 0.85%, has been an 8.85% increase over the past 10 years. So we have tried to continue to make the best use with the fundings that the county does provide to us. We're also taking a look at making some necessary improvements to facilities. So what have we done? What have I done in the past 6 months? In recognizing that we have a transition occurring, when we've lost positions, I have not refilled them. I'm trying to put the health district in a position where we can be as flexible as possible and pivot based on the needs of the counties. So I've also consolidated positions. I've moved some programs around to be more efficient with our program delivery. But what I want to do is I want us to be in a position that in the next 6 or 8 months, when we have a better idea of what's happening at the federal level, that we can again pivot as needed and pivot to meet the needs of the county and the citizens. We did build in a 3% pay increase to try to recruit and retain staff. That has been a challenge. We've made an investment in infrastructure. Some of our buildings are meeting the 20-25-year-old. We've had things that are starting to fall apart or need repair. So there's some, Christine will speak to that. We, as I was mentioning earlier, did build in some additional capacity in our opioid settlement funds and our use of those funds to take programs, prevention programs, and additional services out to the community. So expect to see that in literally coming months. Some of those larger changes were made simply in the last, probably the last 6 or 8 weeks. So fairly recent changes. I think that's all I have as sort of a preface to what Christine will provide. She'll go into the details on the numbers, and certainly if you have any questions for me as we go through this, that's why I'm here.
Can I ask you a question on you said that you didn't refill positions as people went down, but that still made it so that you needed a 3% increase. You couldn't pull from that, or are you holding those FTEs to fill potentially later based on federal funding?
What you'll see in the budget is there is an overall decrease in our personnel. So for this fiscal year, yes, we could have, but there'll be an overall decrease in our personnel costs in the coming year, but we did build the 3%. Is there a better way to answer that, Christine?
Well, we built in a 3% increase, which the dollar difference is $167,000. That was the dollar impact of the 3% increase. What we should also mention, though, is the fiscal year 25 budget was budgeted at FTEs of 100, and the fiscal year 26 budget is at 91, so there's a decrease of 9 FTEs in the fiscal year 26 budget.
So your overall dollar amount of increase is going to have when it comes to the personnel, it's not that big of an increase.
It's a decrease, actually.
Yeah, the decrease.
It is a decrease.
Because you have a decrease.
Of approximately $430,000.
Okay.
The other thing that should be mentioned also, though, is health insurance increased by 10%. It went from approximately $13,000 per individual up to, I think it was $14,130 per full FTE.
And so one of the things that I wanted to have the conversation on is in terms of the benefits when we're looking at the FTE. How do you guys set up your benefits? Are you guys paying 100% and the employee pays nothing in terms of the compensation package? When you're looking at increase in the rates for competitiveness, are you looking at the compensation as a whole to be inclusive of what benefits you're paying out?
We follow the state model, so full FTEs, and we can provide further information if we don't fully answer your question today, but full FTEs, the employee does have to pay a certain portion of their health insurance. The health district does provide the majority of that health insurance cost. And if the individual goes down to 80%, there's still a portion that the health district pays that's still considered basically they're compensated in health insurance, I believe, at the same rate as a full FTE. But then when it graduates down further, then the health district does pay less and the employee does have to pay more. The exact dollars on that, I'm not sure what they are.
The reason I ask is there's a difference of when we're talking about making sure we're competitive in the market, some people get all of their benefits paid, and making sure that we're calculating in the value of healthcare when we're talking about the market, the labor market, because that's a huge piece when you're working for a government entity or private. Its benefit package actually matters. It's not just the rate of pay. So that was a question, especially when you come into the budget discussion and building in that 3%. We need to make sure we have that discussion to show why we're doing that still. So thank you for that answer, and that does answer my question on that. Clerk Rosedale?
So you said that the levies or the amount you're asking from the counties hasn't gone up, and I think that is correct. The amount that Bonner County is going to have to pay went up by $18,000 to about $530,000 because of probably assessed values or population or something like that. But our share has gone up.
That's correct.
That is correct. And as we go through the presentation, we'll see the calculation of those numbers.
Thank you. I just stopped you on the employment because we talked about that before you got in. So that's all I had on what you already said. Anybody else have questions for them before we move on to the
I
rest of
guess
the
I have a
slides?
generic question since I'm
new at this. So this comes out of our property taxes for the county? Are they on
We
the,
levy specially just for this. We have a special levy just for this, but it's part of the
Within.
envelope. It's part of our,
it's part of all, but everyone's property taxes, they have their own
To the
levy
counties.
line, just like a fire district or whatever.
No,
No.
it's within the county, so,
it's like road and bridge.
So it fits within our
It's-
3% cap.
Yes.
correct.
Okay,
Anything else?
thanks.
I asked you first, so I want credit for that. All right, back to you guys.
Yes, go ahead.
So if we go into the presentation here, if we look at this page, this is the county funding. It's just a friendly reminder how the funding is determined by county. 70% is based on population and 30% is based on taxable market value assessment for that county. Next page is our budget. I like to start down at the bottom, look at the revenues. So if we look at the revenue use of program advances, we can see that the dollar change between fiscal year 26 and 25 is a decrease of $368,000. That is essentially a shifting in funding. In fiscal year 25, we were using opioid funding that we had received the year before. So it was included in restricted funds that we pulled from in fiscal year 25. In fiscal year 26, we've budgeted what we plan to actually receive, not pull out of those restricted funds, but use what we actually receive in fiscal year 26. That's why you see the decrease of 368. So those funds that we plan to receive in fiscal year 26 would be under contracts and grants.
And then would those anticipated revenues be some of the ones that we're still waiting to see whether or not they're going to be reduced?
No,
Or is that a different category of funding?
Correct, yeah, these settlement dollars, opioid settlement dollars are a little bit difficult because, you know, there's a total amount over the course of 18 years, but some of these companies that are subject to the settlement, they're paying years 2 and 3 or 4 and 5 ahead of schedule. So we will, and it just shows up on our doorstep. We'll just simply get a notification from the
Currently, we were getting notifications from the Attorney General's
Attorney
office.
General's office.
It has been moved to the State Treasurer's office. They are now managing those funds.
But yeah, we'll just get a notice one day that the check is on its way. It's
It's probably whatever works best for the total financial package for that company for that
Exactly.
year, based on what write-offs they want.
That's exactly right.
Next line item is licenses and fees. We have a 3% increase. Licenses and fees represent environmental revenues. We're being quite conservative going into fiscal year 26 because we do anticipate seeing a bit of a slowdown in construction there. Next line item is health services. There's an increase of $82,600, a 6% increase. That $82,000 actually represents an increase in Medicaid revenues specific to our home visiting program. Last year, we were approved to receive Medicaid. It wasn't the full year that we received it in fiscal year 25, so that's why you're seeing an increase in 26. It's the full year of anticipated revenue that we expect to see in home visiting coming from Medicaid revenues.
So do we have a metric for how much Bonner County is using that service?
Yes.
Okay.
In our home visiting program, we have 2 programs. We have the Nurse Family Partnership, where a registered nurse will go in and work with lower income, higher risk, a lot of young mothers with children that are looking for, and provide a variety of support in it. And then we also have the Parents as Teachers, which is a health education specialist that provides similar services. In the last calendar year, we had 211 visits in those 2 programs in Bonner County.
And is that an increase from the last?
I don't have a comparison from the year prior in front of me.
Can I email you for that? Because I want to see what the increase in Bonner County is, because I'm looking specifically, especially with Panhandle Health, on what we are contributing into Panhandle Health and how much our county is actually accessing from Panhandle Health without the traveling to Kootenai County or another county, but how much the service is specifically available in our footprint, because we need to build our services in our area for better care of our residents. And so I'd like to see if we're increasing that, and then how we're getting that information out to Bonner County residents of the availability of that program. And then as a side note, can we have this as a document, USB, so that we can post it, so that when people watch this video, I'm sure people are wondering, what are they looking at, so that we can show the public this document, please.
I can do it. One of the challenges with that program is it's most of the funding we get from that is through state appropriation. I think McVie is also a federal source.
McVie is maternal infant early childhood visitation program, or visiting program. And it is funded through Health and Human Services. It is a sub-grant that we get through Department of Health and Welfare. And there's 3 models that you can follow. I won't get into those, that's not my wheelhouse, but we do follow the NFP model, which requires an RN. So that is federally funded. Then there's a portion, the home visitation program, PAT, Parents as Teachers, that is funded by a state appropriation. So the state appropriates that money goes to Department of Health and Welfare. They in turn forward that money to the district, not as a grant, but forwarding the appropriated monies.
And then when you look at the reports out of Kootenai County for the mothers that have used that program, they find it a very valuable resource. When you consider in Bonner County, we no longer have the birthing here, that's a resource that would be valuable in our area, but people need to know it and be able to access it. And that's in part of when we're looking at the budget, I'm looking at how much of that is available to our people where we are, and how much the increase is of using it from the past. Because we just had an incident with a person that had no prenatal care in our community. And it's an opportunity to help, because it impacts the county and it impacts public health, because that's part of the clinical services aspect of it. So that's why I wanted to see that number, because that program, a lot of the mothers that have accessed it have said that it was valuable and a good resource and a support system for first time. So,
And my understanding is those programs are all at capacity and demand. There are wait lists to get onto them. In recognizing, part of the broader goal of Director Adams at Health and Welfare and trying to keep families together, we did allocate some infrastructure funds that were available to adding another NFP nurse to our services to pick up another set of clients. So we are looking to expand that again with some funding that's currently available, but can certainly get the information.
So are you guys aware of what program they're talking about? Yeah. Okay. All right. Thank you.
Would this be the appropriate time to ask? It sounds like you guys are state funded and federally funded and county funded. So can I ask what the county funded part covers? Or are you going to go into that later in the presentation?
We don't go into the presentation. The presentation does not go into detail as to how the county funds are used. But to answer your question, the county funds are often used to support other programs. For example, home visitation, the home visiting, the NFP program, they may need to be supplemented by county dollars. So when we're developing the budget, in order to balance their portion of the program budget, we may need to put county dollars in there. Another program that also receives some county dollars is the WIC program. So it can be distributed based on any program's budget for the year and what is needed to balance. So county dollars are used to supplement some of those programs.
On the WIC program, a question came up with respect to legislation. Are you guys gonna, what's the impact to the change in legislation with related to illegal immigrants and the WIC program? Because in some cases, there was an understanding that there would be a reduction in what was being paid out. And how do you guys manage that from following the rules related to that and the impacts to that particular program?
I hadn't heard about a reduction. What I had heard is there is an identification requirement now that didn't exist prior. So individuals coming in for services, they're going to have to, I believe, bring in 2 forms of ID in order to qualify for services.
And and the reduction of services was the kind of an assumption that the program does have a population that would then be denied services based on the identification requirement? You're not thinking
We continue to work with health and welfare on that. I have a meeting coming up with them on the 12th. In the meeting we had with them last month, they're still sorting out what happened at this last legislative session and exactly what that means and exactly how we're going to move those programs forward.
Question?
So it's my understanding that some of the services in Bonner County have decreased a little bit for some of these programs, but our portion of the tax is going up. And you had mentioned this because of our population growth and that. However, the population growth and the real estate valuations come with their own fees. When people apply for septic permits, that's a permit on top of the levy. So we are paying more in our levy, but getting less services based on other counties. Can you talk about that?
Yes, and I would say that the best way to answer that is I will take ownership of that, is that anticipating the transition. I mean, looking at the additional work requirements for Medicaid expansion, looking at the federal level, and they're starting to talk about potentially eliminating Medicaid expansion, as a means to find $880 billion to balance their budget. And what that means to me is that I expect that there will be more uninsured individuals, more people seeking care. There are, this is probably going to be part of the discussion on Saturday, but really to me, and I've already started this, is conversations with federally qualified health centers and with hospitals and making a decision on how each of our entities can best serve the citizens in the best capacity. And maybe to better answer your question, hiring nurses right now is exceedingly competitive. It's exceedingly competitive. And not having an exact idea of, I don't believe that this is a status quo type of situation that we're in moving forward. And so what I don't want to do is hire on a number of nurses and staff this office if that's not going to be in the best interest of our county commissioners or our citizens. So I expect that while there is diminished services now, and I believe that the reason that there are is because we haven't paid what you have to pay to bring nurses on, but when we have a better idea of what that looks like, services will be brought back up to the level. And I expect that to, again, be in coming months.
Healthcare has been significantly upset because of the Affordable Care Act. It has offset a lot of things, and nursing we're stuck in that very high rate of pay and competitive situation from COVID. That actually impact has not changed in healthcare. It doesn't really pay to be committed to a provider. That's not where the money is right now. And it's part of the infrastructure. So that one's hard to guess at what's going to happen. And I think the federal government, looking at the Affordable Care Act and those impacts and Medicare combined, will address and kind of have that trickle down of what's happening on the ground here, because we're still in contract nursing rates, which is astronomical. So,
And,
I don't-
and to touch on that, my understanding is changes made in Idaho after Medicaid expansion that impacted the indigent funds, that where the state no longer provided an appropriation to the health districts, but instead put that burden, put that responsibility on the counties. I don't expect the state is going to stand those back up, which is again why I think that there is an important conversation, and it's already happening at the director's level. We talked about it. We're going to reach out to representatives of the state FQHCs and the hospital and start that conversation.
that redistribution of costs to people that have insurance increase their rates, which then creates even more people that have difficulty affording health care, because then the people on one end of the spectrum are told, you don't have to pay anything, but the other spectrum is paying a lot more. And so you have more people that are not actually doing preventive care that then become in need. And that is, there was a bill to say, as we're trying to collect those fees, that you can't send it to a collection agency and then they inflate what their collection is. We've created a problem with that act. So we'll see what happens.
Is the health district filling a void for people that fall through the holes that don't qualify for certain government programs or sliding rules? Or are they competing with private enterprise such as Knitsu here? Are you guys providing the same services?
Well, we do provide similar services to Knitsu. We have historically been, we do have a sliding scale, so individuals that are uninsured or underinsured do seek out our services. And again, that's where the conversation lies, is that I don't want to provide duplicative services or compete for nursing or medical staff against other individuals that are serving the same population. But the question is I do think that we have a role in the change that's coming, and that is going to be a conversation that this is the conversation. When I talk about when I preface the budget and I said there will be a conversation coming, it's not going to be about environmental services, probably won't be much about WIC. It's truly going to be about clinical services and what the need is and how we can fill that void if there is a void to fill.
I think
There is in terms of the clinical services aspect, it's not really the idea of a health district having clinical services. It's not competing with private industry. Private industry doesn't have the capacity as what we're seeing in this area. There's not providers in the area, and there are wait lines. And the idea of the Panhandle Health is it's not just the sliding scale, it's the additional availability. And the problem is in some ways that it feels to some people like, well, we have doctors, and if you just close, then they would get more service, but they're not, because I will tell you in looking at other areas, for example, I'll tell an experience in California, trying to schedule an appointment, you need to have insurance to schedule the appointment. But then you need to have a credit card in order to actually be seen. And so if you don't hit all of those matrix, and this was a person that we were working for a person in a mental health crisis, we could not get into the appointment without insurance proof, a credit card on file, and you're arguing with them, well, not every person has a credit card to give you. We now have an insurance card to show you. You are not allowed to cash pay for services like that. And some of the businesses are structuring that way because some don't want to deal with insurance at all. Some need insurance as a backup plan. Some people don't want to deal with Medicaid, Medicare anymore. And at the end of the day, some patients need to be able to go into kind of that walk-in community clinic. Unfortunately, that our system is set up that way. And that paradigm is coming our direction because in as much as people say healthcare should be free, I paid to become a nurse and it's a job. And so how do you get the money that affords the person to work there? And we are not, that paradigm is coming because providers can't afford to be providers in our area.
Oh,
That's probably a good segue.
there, There is some funding that goes into clinical, such as women's health care, women's health check, Title X services that help families with family planning, their reproductive health. There's an HIV STD contract, which is clinically focused. So there is federal funds that are going into clinical services. And those are just basically the three primary examples that we have. And as Eric mentioned earlier, though, our funding is a bit uncertain, so we're not exactly sure, will they continue to be funded? Are we going to see a reduction in funding? So there is currently funding available to assist those clients that need that type of service.
There's a branding question that I've been asked. I kind of agree with this is we advertise women, infant, and children, but there are men that are the primary parent, and it doesn't look like services are available for the male population. To include, yes, we have reproductive health, but we also have males that are not feeling like there's a service available because we often specifically only advertise the services for females. Because males who are the primary parent of an infant do qualify for those benefits, but by the way it's branded, it looks like it's specific to women. So are we going to see a change in that so that single fathers who have their infant children between those age groups know that they could apply for those benefits?
We can probably do some work with that, but because it's a federal program, there are usually stipulations with how that information is.
It's all women infant, but males qualify for it.
No,
too.
you're absolutely
And it doesn't
correct.
tell you that. And so when you're in healthcare, when you're saying, well, go apply for WIC for that, well, no, it's for women, but it really isn't. It's just that's how it got branded. And so what are we doing to help our residents know that single fathers of children through that age group can qualify for those benefits?
And I'll talk to our PIO. on
Okay.
that.
I think there are still potential overlaps in services on the clinical side between federally subsidized entities like Connexu and Heritage Health and the PhD that still need to be explored, but I think that's the primary purpose of Saturday. So those are questions that I have for the Saturday workshop.
And that's where I have some concerns on an inability to answer those questions simply because we have looked at, I guess, what's called the skinny budget from the Office of the President to Congress and what he's proposing. And some of that proposal does involve significant reductions in HRSA. Well, Connexu Clinic and Heritage Health, which are the FQHCs in the area, they rely heavily on that funding to keep their doors open and then also billing to Medicaid. So part of the question to me is yeah, I agree with you. There is a duplication of services, but there also is limited access to care. But that's where I think that it's going to be, the solution is going to involve everyone, because I expect, maybe I'll be wrong, that FQHCs may be significantly impacted and their ability to provide a broad range of services may be reduced to where we need to work with them and with the county and say, we'll do these things. You guys focus, your available resources on these things, and that's how we can best move forward and serve the community.
I feel like Saturday's conversation should be happening after we have the post, and like we're going to have to redo it.
That was comments that I made at the last board meeting, was that when the federal government builds their budget for the next year, we'll have a much more firm idea of what's being funded and what's not. I do have tentative meetings set up with Mike Baker, who's the Heritage Health CEO, in July, because I expect as days go on, we will have more information on this. But I do believe, and this was a conversation I had with the other 6 directors, and we're starting this at the state level too, this is a much larger conversation. We're not continuing status quo. We need to decide how we can best serve the community, because in talking with Seth Grigg, right now with some of the safety nets that have been eliminated, at this point, if the health district doesn't provide services, and if Connexu Clinic, if the FQHCs have limited services, then what you have is the hospitals. You have the ERs, and that's the most expensive form of healthcare. And And at some point, how long will the hospitals be able to do that, especially some of these smaller community hospitals that don't have the funding to continue to provide significant free services. So that's,
Where you see an increase of ER visits for things that are not ER visits, and we don't have the indigent services, and the expectation is community hospital is supposed to basically write much of that off, which doesn't really get written off, it just gets shifted to a different population of payer, which then creates a greater problem in the community as a whole. So,
yeah.
okay.
So that is, to me, that is the number one conversation that we'll be having the next 6 months.
Maybe this is the point where we should ask, and we typically ask this at the end of the presentation, somewhat in our summary, but since the discussion has basically been on services, we've been asking, what services are you needing to see in your county from the health district? We've just had the conversation on clinical and home visitation, but what other shortcomings do you have in your community?
Mental health.
Potentially the health
Mental
district.
health, the line is long. The crisis issue, I have an issue with the access to 988, so I sit on that particular board, and to find one of the House bills restricts minors to using 988 because of the parental consent clause, that's a huge issue. We've been trying in West Bonner County School District, as you know, to get even students more trained in helping, because they're sometimes the first point of contact. But mental health is an issue. We have per capita more of the suicide when you look from Bonner County to Kootenai County. It's a different metric, because typically we see nationwide, you see more females, we have more males, and we don't have an impact of how do you reduce that. And in part, it's the services. It's not like having mobile crisis unit and things like that that's a 24/7 need of availability and advertisement of use. So that was going to be one of my questions, is what is PhD doing to help with moving legislatures at least on the parental consent issue that disrupted 988's ability to receive minors calling?
That's
I know it is, but that's our huge one. Bonner
No,
County is huge on that. That is we're going to do behavioral health board today, and it's going to be another suicide in there. And so that is a service we need. I work with Dr. Lossif. We've increased our number of therapists since last year. We have a total of 11, but that's not enough. There's still a line. So yes, we have remote mental health, but everyone knows that that's not a replacement for it. And we need crisis. We don't have a center that has overnights up here. So if that were the magic thing of Asia could have something from PhD in Bonner County, we need actually overnight mental health room, which is a goal of Connexu Health, but there is no funding for that right now.
I was going to say, we're in a similar boat. I mean, a lot of the funding that we have seen over the years, it's stayed level, which is essentially a reduction if you're trying to provide the same level of service. So that continues to be a challenge. Certainly, we've had conversations with internally that have touched on mental health. We're more in prevention, but as we talk about the opioid settlement funds, possibly having a case manager or trying to, branch out programs from that because the funding is stable. That is something we're taking a hard look at, over the course of the next year. But we're probably in a very similar boat to Connexu as far as being able to expand into that realm.
Well, and there needs to be some rebranding from the idea of mental illness to mental health as no different than physical health. And the stigma of not getting treatment, people go through days of just being depressed. That is a normal human response. And we're not treating things before they become problems. And there's a reason to pull opioid money because it's part of mental health. And so that is what Bonner County needs, is more access to that. And more psychiatrists, not just therapists and counselors. And in our community, there is a view of wanting therapists that are in line with the beliefs that are up here. So more faith-based therapists, conservative therapists, and psychiatrists, psychologists. That's what this area is desperately in need of. Every month, it feels like we're getting a suicide or suicide attempt. And I would like an answer on what is PhD doing to address the minor access to the 988.
And just to touch on that a little bit, really, it's been, my position to the other health district directors is that we try to fold in with the counties and with IAC in pushing that, those type of changes or those type of requests forward. And the reason that I say that, and to be just absolutely blunt, is since COVID, the health districts do not have a whole lot of political capital to throw around. I mean, that's just it, is that there's a few things a few efforts that were made in this last legislative session in a couple of areas, and I will just say we were very quickly put into our place. So that's where I think it's important that again, that we work with the counties. I think the counties have greater sway with regards to elected officials. Or at the state level. It is my goal, and I've already started made a few appointments to meet with all of our area elected officials to talk through a number of these issues prior to going into the next legislative session, just to share my thoughts and ideas and maybe try to make a little bit of headway.
So if the advisory and policy committee puts together a resolution that's similar to Wyoming, where they address some things related to behavioral health crisis, kind of in line with Good Samaritan, would Panhandle Health bring it as a conversation as you guys go to be in front of other elected officials? Because that, outside of the other things that were requested as amendment, I think it was the Senate Bill 1199, it specifically addressed the 988 for minors and specifically said it had an issue because they want parental consent for a minor to be able to have access to 988, because 988 is an access agent it's signed up with some behavioral health. And so then 988's response is a concern of whether or not they received that call. They're asking an age. That doesn't deal with the crisis. And so that feels like that should rise to an urgent level when you look at the top 5 northern counties' suicide rates and the age bracket that we're talking about. So we're talking about we're restricting more than 50% of access to potentially prevent that, while we equally are trying to train people in schools to be able to help with the QPR and reduction in suicide. So that to me should be an urgent thing for all of our counties, but for Bonner County, we are higher than all of the top 5 per capita in suicide. So that's a service we need for our minors.
I will incorporate that conversation, because I can tell you that change in law impacted all of our services, because all of our services, well, except for our environmental services, but all of our health services, WIC, all of them fell under that, to where, if you're under 18, or between that 14 and 18 range, you have to have parental consent for any service that you receive.
Thank you.
Is there a program that you guys have for like nutritional training or coaching, or it seems like the medical field today is so into treating the symptoms, but what about preventative medical?
I believe that a large part of the WIC program does incorporate that as far as nutritional eating. I know a lot of the products that are available do have to meet certain nutritional guidelines. So I would say a large part of that, we have licensed dietitians in that program that are providing that guidance and direction to individuals that qualify for the program. So that is actually.
It just seems to me like if we're talking majority of the population, I think the majority of the population would benefit from having nutritional information, and I mean real nutritional information, not the standard yada, 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 protein, fat, carbohydrates type of thing, but what is actually causing a lot of our illnesses and our medical issues today? And I see it as environment and what we put in our bodies. So are we wanting to address that, or are we just wanting to keep expanding medical facilities to keep treating what the byproduct of malnutrition is creating?
No, and I do believe that we're effectively, within that program, we are providing nutritional services to try to promote healthy lifestyles and prevent chronic illness. I think what you're alluding to.
I think that the bill that passed that restricted when you're talking about public assistance and ability to buy like the sugary kind of food, that increase is going to benefit in that kind of way. There are free programs within communities outside of PhD that offer nutritional education and training. I think the problem is, as a whole, society is told it's a different message. And I think one of the things at the federal level that's going to change is you're going to see the food pyramid actually change, which is going to, I think, provide a different form of education. And I think hopefully that trickles down to, on public assistance, is it reasonable to address what can you buy when you're talking about public assistance? And I think those are the things I think that PhD will see as the federal government start shifting and addressing some of those kind of food choice availability issues.
And I hope to see that. My understanding in talking with Kim Young, who oversees our WIC program, in Washington, you can use some of those benefits to go to farmers markets and get fresh fruits and vegetables. But because it's a federal program, there's a process to get a waiver to do that. And because I will say we don't have a robust the resources, not at the health district, but even at health and welfare, don't exist to petition the federal program to have alternative uses for the benefit. So I agree, if there are changes in the requirements at the federal level that allow for better food choices, I think that would be
management too, because we shifted to an encouragement to buy generic to buy brand name, which costs more. And which means that you're saying you need more in terms of the benefit versus there was a period of time when there was education and nutritional training on when you're on public assistance, this is how you stretch your budget, versus we've shifted the opposite to buy the brand name, even though it's less quantity because it is a brand name and it costs more. We've shifted the mindset with a little bit of you're owed to be able to buy that versus the person who isn't on that says, I can't afford to buy that, I need to buy this kind of deal. And that shift is going to come from the federal government because they're the ones who put the sticker on which product you can buy in the store. And that's
Exactly
the
correct.
problem. It's they put the sticker on the brand name versus the cost-effective
And
product.
there are items we simply don't have flexibility to change
Yeah.
in order to administer the program.
There's a list of what you use it for. So,
It has nothing to do with lobbyists, I'm sure.
yeah.
So one thing that I'm kind
General
of hearing
laws.
is we're talking about low-income people, government assistance, is what you guys are really focusing on, I think. And an issue that I have is that those people aren't really contributing to fund this. As far as the health districts go, it's the middle class and the upper class people that are funding this. And my belief is tax dollars always should be used to help serve and benefit the majority of the taxpayers. I don't see that happening a whole lot in this situation. That's why I brought up, are there ways that the Panhandle Health District can help those that are not on government assistance, those that are not taking advantage of or using WIC or these other programs that still fall into a lot of these categories as far as needing help with nutritional education and things like that. Or I'm going to go outside the box here a little bit, but outside of Western medicine, with vitamins and minerals and herbs and all those kinds of things that help keep a body healthy, to where they would not need the medical services as much or any at all. So I guess my question is, how do we use the taxpayer money to actually help benefit the taxpayers a little bit more?
Well, and maybe partly to answer you, I guess the way I view, and I don't have the numbers in front of me, but I view the WIC program or some of those programs as helping people in a moment in time in their life where they need an opportunity to step up. I believe that most of the people that we have receiving services, they're doing so because, you know, they're the working poor. You know, they don't, I mean, health insurance is expensive. So I do believe that a lot of folks that are coming in, they're at a time in their life that they need an opportunity to, a hand up, if you will. I'm sure that there are individuals that are perpetually on a number of these programs, but I'm just gonna say I grew up in Boundary County. I have a conservative fiscal mind, but I also do believe that at some fundamental level, we want to provide paths forward for folks where they can step back up and move back into the workforce. But I would expect that a number of the folks that are receiving these services are paying taxes, are working to it.
That's a question. You were talking about family and health and reproductive services. Is that to keep the moms and the babies, even the infants in the womb, healthy?
Correct.
Okay, so you're trying to keep the unborn babies healthy.
Yes.
Okay, great.
I think in part of what Commissioner Corn, I think it's the societal view too of government programs that see the same people that come through and it becomes a supplemental income. And when you look at that, then part of, and what I'm hearing him say is, what does the person who is not using that get out of Panhandle Health in terms of resources for what they're putting in? And that's, the reality is in part, it is a redistribution of wealth. That's what you're seeing as happening. And then the question is, what are we doing then to reduce the need and increase the independence of people such that someone says, I can't afford to have another kid right now because I am not able to, instead of I can because I can just apply for that. And that's part of that education and training of, yes, we're going to help you here, but it doesn't become a replacement. And that's partly on the conservative view is a little bit of the government becoming a supplemental person within the home versus the government saying, I helped you, not just in the crisis moment, but to not need the service. And in some cases, you have people that, here's my first kid, second kid, and they're always on the program itself. And where's the education of, is that person growing the need for the program that increases the percentage that the person that doesn't get anything out of it? And that's a huge issue, not just for, I mean, it is the problem of government getting in to help with those situations versus members in the community having to go to members in the community to say, I'm going to the food bank to supplement my need for food.
Right. Providing assistance to step up without creating dependence on the program.
And
No,
there's a percentage
Yeah,
of
that's
it
the
that is
challenge.
dependence, and it's, how do you fix it?
Yeah, we have to reduce abuse, which is a huge challenge to figure out, because my general mentality, I think, is similar in that I believe we have had decades of an inappropriate perspective that government replaces charity. And that's not government's role. That's the role of the individual and the charitable organizations. So I think we do need to find a way to move in a direction to reduce abuse. I totally agree with the idea of giving somebody assistance and a hand up, but where that comes from and why, I think, is really the fundamental question that needs to be answered.
And as dovetailing on that, and when you look at groups that get to claim nonprofit and not contribute to the tax base, and that's part of what they're doing, but is, in a way, is Panhandle Health's resources removing the obligation of the person who's receiving non-exempt status from taxes from helping the community that it is not paying the taxes in, which is a very big picture, but when you look at it in a way, we have shifted to saying government will meet the need, but then look at the number of churches and facilities that we have in our counties that don't contribute to the tax base. What is their contribution to those types of services that they used to do? And now we're paying tax money for PhD to do it. And I think that in Bonner County, our residents are wanting to see a shift back to the community taking care of the community, because in part, I grew up with ins and outs of public assistance, and my goal was to never be on public assistance as an adult. And that's not a negative thing, but we've made it negative and said, let's give a credit card versus this, because we want you to not see it. But there's value in having that, a little bit of the, oh, I had to pay with food stamps, because it gave someone a goal, and we have removed that, and our budget is growing because of that decision. And then we look at our churches where a good amount of their services actually are outside of the community that they don't contribute their tax money to. And I think that's in part of why are we using Panhandle Health to supplement that aspect. And we can't fix it this budget cycle.
No, but I do, I mean, but this really all does come back to kind of some of the early talking points is based on, I mean, again, about you'll see about 50%, and we do need to jump back on this just for your folks' time, but you know, if 50% of our funding does come from the federal government, I mean, or through the state, what they determine are priorities in spending or assistance is going to cause us to shift. And I do think, and particularly in the topics we're talking about in clinical services and whatnot, it is important for the health district to be proactive. This isn't the status quo that we've had for years. This is about working with area partners and deciding what role we have and what's a good use of county support dollars. That's where I wholeheartedly believe this is transitional. When we have next year, when we're sitting in front of you having the conversation, I expect it to be a very different conversation as far as services.
Okay. All right, we'll speed through the rest.
Okay. Right.
But good conversation.
Yes, I appreciate that.
Okay, let's jump to contracts and grants. We're still down on the lower half in the revenue section. We can see that our fiscal year 26 grant revenue has decreased by approximately $75,000. As mentioned, we've had a reduction in some funding. It's still a moving target at this point. And moving on down, donations, other change of $2,600. Donations, obviously, you know, people donating, other purchasing card rebates, that sort of thing. Very much a miscellaneous category. And interest, an increase of $95,000, simply because I was far too conservative in budgeting interest in the prior year. So that one's on me. If we move to the next page, we have our pie chart. We can see that in the blue section, 49% of our funding comes from, excuse me, I apologize. We might want to look at our expenditures before we look at our pie chart.
At a high level, we can look at the numbers exactly.
We've already talked about our salary and wages. We have a 3% increase. We've talked about the change in health insurance, a 10% increase. Operating expense, the only thing that is different in our operating expense is, and this may sound familiar because a couple of our objectives were not met in the fiscal year 25 budget, so they've been included in 26. We need to do a carpet refresh in the building. The building is over 20 years old now. We have some wearing. We have separation from the main level, the concrete, and it cannot be repaired. We've had people in to make that assessment. So we're budgeting approximately $200,000 for a carpet refresh in the building. And we also have a computer refresh. Our systems have not been updated since prior to COVID. We had hoped to get that done in the fiscal year 25 budget. We have not, so we're moving it forward into fiscal year 26. And parking lot maintenance throughout the 5 northern counties as needed. Other expenses are HVAC system, as Eric mentioned. We have, building issues going on. Our HVAC desperately needs some assistance. That's coming in at about $139,000. That's in the Hayden facility. And badge access system in the Kellogg office, and some landscaping of about $20,000, which was included in last year's budget for Bonner's Ferry. Did not get done. We've moved it into fiscal year '26. Trustee payments and benefits, that's an increase of $255,000. What trustee payments are payments that are not specific to Panhandle Health, not like our operating expense. An example would be individuals who, or organizations that apply for opioid settlement funding. If their project is approved, if they complete their project, then we will reimburse them for the costs of their project. That money is coded to trustee benefits. It's just a pass-through of funds. It's not our cost. If there are no questions, then we can move on to the pie chart.
I'm sorry, so you're talking about your carpet refresh and your computer refresh. You said that hasn't been done for like 5 years, is that correct?
It would have been prior to COVID, so probably fiscal year 18 or 19.
Okay.
I'd have to look specifically. We in the past had tried to do it every 3 to 4 years was the schedule, but we're quite outdated at this point.
The carpet's original to the building, and it's starting to bubble up in the spring, or in the winter time and different things where it's worn out.
In some areas, it's a trip and fall hazard. In some areas. Any other questions?
Thanks.
Our pie chart. Blue section, 49% of our funding comes from contracts and grants. 28%, the yellow section, is fees. 21% is the county funding coming from the 5 northern counties, and 2% is that miscellaneous revenue such as interest. Now, the next page is the nitty-gritty. Keep in mind that the allocation is based on the population and valuation changes. So Bonner County, in the top half of the page, had a 19% increase, or excuse me, that's the allocation amount, I apologize. To the far right, they had a 3% increase in population, 1,400 in census amount, and the lower half, the valuation percentage, increased by 11%, or $1.9 billion. The source of this information comes from the population, comes from the U.S. Census Bureau, and the valuation comes from the State Tax Commission. Yes?
So the last census we had was 5 years ago. So how did it go up between then and now?
Well, this is coming directly from the U.S. Census numbers at the, just a minute here, having trouble seeing. It's
2024, so even though,
Well, they have a
I think you're
25.
thinking of when they send it out and ask you to fill it out, but they're still collecting census data, and you can go on their website and see
Correct.
the increases that they're documenting based on, kind of like this, when you start using services, then they start tagging you even if you don't fill out that form.
So if you go online to their website and go to the U.S., the population division for the release date of March 2025, that's where this number comes from. And then you'll be able to see the prior year as well. What I have noticed is that there can be additional updates. Sometimes the numbers will not match exactly to the prior year.
How'd they get those numbers?
Yeah, I wonder too. I don't know what their metrics are, but they do update them all the time. Do you happen to have any information? I'm really curious as to how Kootenai's valuation decreased.
Well, it's the shift and drift that we often call this the shift and drift page. But I think
BOE's dropped.
They had a lot more construction, like Tens of thousands, couldn't he?
But the new construction, if it's staying within the developer and it hasn't been
It hasn't
released,
sold.
that could be what you're seeing as shift and drift in the valuation. And so then it'll be the next time you'll see that they'll have the increase.
So they might be getting the non-tax
Yeah,
on the properties that the developers hold before they sell them.
yeah, because they've got quite a bit of tract houses down there that aren't occupied yet, so that could be what you're seeing.
So if we take these calculations to the next page, we'll see the dollar impact to Bonner County. The top portion, the top half, the grand total, we can see that the allocation from Bonner County is calculated at $531,972. Looking down towards the left, the change in support, that represents an $18,176 increase compared to the fiscal year '25 ask. And that's our fiscal year, not the county's. It's a 4% increase. Are there any questions?
So the money coming from Bonner County for fiscal year '26 would be the 531,000, or that's,
That concludes the budget presentation unless you have questions.
Any questions from the board?
I got plenty of questions, but not regarding this.
Okay. All right, Clerk
That makes
Rosedale?
sense, thank you.
Okay. Commissioner Donkey?
No, the numbers are clear.
All right, it is 10:07 and we'll adjourn this meeting.
Thank you.
Thank you.